Definitely by His mercy and His grace, we are grateful. And this is Ultimate Health on Joy 99.7 FM with me, Nortey by nature. Yeah, I'm sure you enjoy the, in-flight entertainment, huh? I've got Dr. Michael Macarthy seated and rested. We both swung from, he swung from Tema. I came in from the Teshinungwa Greater area. But by His grace, we're here. Another edition of Ultimate Health. If it impacts on your health and your well-being, we'll definitely talk about it. He's a consultant obstetrician gynecologist with the Sinel Specialist Family Hospital in Tema. I know some of you want me to say Tema. Tema. Yeah, today we're talking about an obstetric procedure, external cephalic version. Doing the baby flip, huh? Turning your unborn baby, yes, your unborn baby. Who is doing the turning? Who is qualified to do the turning? And why do we need to do the turning? And is it safe at all? That's why I hand over to Dr. Michael Macarthy, who's in the studio with me. Uncle Mike.
Hello.
Charlie Akwaban. Charlie, looking sharp.
Thank you.
Charlie,
Thank you so much. It's Sunday, so we represent.
Oh, you are a spitting image of good things.
Thank you so much.
Great to have. I know you've been in surgery, or is it theater? What should I say?
Yeah, it's been interesting. It's been an interesting morning for me.
Wow. Okay, obstetrician gynecologist, we rattle it all the time, but I like to keep my listeners up to date, up to speed. When we say an obstetrician gynecologist, what does it cover? Or who are you?
Well, we specialize in the area of medicine that has to do with women, more specifically the reproductive system of women.
Okay.
So we deal with everything that has to do with the uterus, with the ovaries, the fallopian tubes, the pelvis, and of course the psychological aspects of that as well.
All right.
And then we also deal with issues of pregnancy and so on.
Menstrual
cycles, pregnancy, how to get pregnant. Once we do get pregnant, there are a lot of other things that go with that, and how to get this pregnancy safely to an end and to effect a delivery that results in a healthy baby, a healthy mother, and a happy dad.
You see now? So it tells you that, Charlie, when it comes to the obstetricians and gynecologists, they should be in and out of this juju big time, all the time. How to get pregnant. Charlie, it's a whole
topic.
It's a whole topic.
Let's not start.
Let's not go there. Even when we go into assisted reproductive, techniques, IVF, we'll get there. But today, we brought some big broth. External cephalic version. All right, cephalic head, right? External, outside the body. But what the heck is that, Doc?
Well, in medicine, we have to give names that you can't understand so that you not be sure of what we are going to do.
Right.
Yes, so external cephalic version is the situation where we actually turn the baby from a position where the head is up to a position where the head is down. And we do this from the outside of the body without any surgery, without any manipulation inside the body.
Okay.
So that's why it's called external. And it's called cephalic because cephalic is the head. And we are moving the head's position from one point to another. In this case, we want to have the head down.
Okie dokie. Folks, if you've just joined us, this is Ultimate Health on Joy 99.7 FM. Your ultimate guide to health living. This is every Sunday, 2:05. I've got Dr. Michael Macarthy in the seat. He's the CEO, consultant, obstetrician, gynecologist with the Sinel Specialist Family Hospital. Right? Family, all of you. Sinel Specialist Family Hospital. Today we're looking at the manipulation that allows, let me just start by saying, a qualified person who knows what they're doing, to flip your baby if it is not properly positioned for a safe delivery. Let me say that. Doc, am I right in saying that a qualified person must be the one undertaking this manipulation?
Well, remember that this... You're trying to turn the baby, but it's not only the baby that's in the uterus. The uterus has other contents. It has fluid, it has an umbilical cord, it has a placenta, it has the uterus itself, So there are quite a
Before
few
pastors get into the all sorts of
Well-
laying hands and yetiabonsam and all that. Clarify that for us.
Well, if we are laying hands in prayer, I think that's okay.
That's
But
okay.
actually telling the baby is not as simple as it sounds. I mean, we make it sound simple, but that's why we give it a complex name so that you understand that it's complex. But a lot of things go into it to understand when it can be safely done,
Right.
how it can be safely done, what time in the pregnancy it should be done. And what must be happening before you can say, oh, we can actually safely do this.
Okay.
And please, this is always done in a hospital. It's
Right.
never done at home.
Okay.
It's never done outside because you need to also have the ability to actually deliver this baby should things not go very well.
All right. So yes, we've turned your head to Joy FM as usual. You're welcome aboard. And many of you also are sending a couple of messages. This is Ultimate Health. We're talking about flipping your baby, external cephalic. I don't know. Is it because the UK thing I see cephalic, cephalus, and which is it?
Well, I think
This
it
is
just
American
it just
and
depends on where you are coming from.
Okay,
yes.
okay.
And
I'm
I
coming
think
from.
I think you're fine.
From
I think you're very fine.
I'm coming from Teshinungwa. But anyway, folks, so we want to understand this. And like Doc said, when should it be done, right? Why should it be done? What's the timing? What are the considerations or contraindications? Why will you not do this or should you not do this even if you're qualified? That's why I've got him in the studio. Okay, so firstly, Doc, woman is pregnant, baby is developing. Why is the positioning of the baby a critical factor to consider and monitor during the pregnancy?
Right. I mean, the reason for this whole thing is that you want to achieve as safe a delivery as possible. And so the position of the baby is really important.
Okay.
The position of the baby could be head down.
Okay.
The position of the baby could be such that the head is at the top and the buttock is down. You could have a situation where the baby is actually lying across the abdomen, where the head is on one side and the bottom is on the other side. We call that a transverse lie.
Transverse, right.
Or you could have an oblique lie, which is somewhere in between these two things, where the head is kind of not really down, not really on the side, but somehow across.
But the baby is at home. This is
A baby is very comfortable.
Bedroom. It's moving around.
There may be reasons why the baby is doing that, and some of those reasons may be quite serious, and so we need to find that out.
Okay.
But coming back to the issue at hand, what you need to ensure that you can get a safe delivery.
Okay.
So if the position of the baby is not right, then you need to first of all diagnose that,
Right.
and then apply the correct intervention. Now, if your baby is lying with the head on the left and the buttock on the right, it's not coming out anytime normally or naturally.
Right.
Because you can't, it's like you have a door. You're supposed to walk through a door and you are lying on the floor. You want to roll through the door. Obviously, you just can't go through that way because you are way longer than the breadth of the door. And so if the baby is lying across, it's not going to come.
Okay.
If the baby is lying oblique, it's probably also not going to come. It's going to get stuck.
Makes sense.
And so some of these things will require cesarean delivery. The issue with the breech presentation, however, where the buttock is down and the head is up, you could actually achieve a normal vaginal delivery, but with some increased risk to the baby. And so in all these scenarios, you are having a risk of going for a cesarean delivery.
Right.
And the procedure of external cephalic version is to change that story around, to turn that story and say, well, before I was going for a cesarean delivery, and now my baby's head is down, and so I can opt for a normal delivery. So that's really what we are talking about. So we're reducing the risk of having a cesarean delivery when you could actually go on and have a normal vaginal delivery. So that's really what the whole thing is about. We're not turning the baby for fun.
Oh, okay. I thought you loved,
we are turning the baby so that we can reduce the risk of a cesarean delivery. And it could either be because it was a breech or because it was lying across or it was lying oblique.
Right. So you're doing all these monitorings and evaluations during the duration of the pregnancy, and you're making sure at every given time of assessment and evaluation, you're sure what is going on with the baby, not just positioning. And therefore, you take all these things into consideration. But you said something which made me want to ask. Are you therefore reluctant, maybe made the wrong word, to undertake a cesarean if it can be avoided? Maybe I'm couching in a certain way. Because we could reduce, the number of cesareans we're doing if we can adjust positioning depending on the things you see and you decide on as the specialist. But is it the case that I would want to do a cesarean as a last resort? Does it come up that way, or I'm perhaps pushing the facts?
I think it's a very good question. It's a very good question. It's a very good way of thinking. You generally, we want to opt or move towards a normal vaginal delivery.
Okay.
Generally, that's our goal.
Right.
Because that is simpler, has less complications, and that has less risk.
Okay.
And so we want to opt for a normal delivery.
Right.
But if there are reasons for which a normal vaginal delivery may not give us the outcome that we would like, which is a healthy baby, which is a healthy mom,
right,
and a satisfied dad,
okay,
then we'll have to find other ways of doing this delivery, and the most serious option here is the cesarean delivery.
Okay.
Cesarean delivery is a major surgery.
Right.
And so that also comes with its risks.
Okay.
And so the reason for doing it should outweigh the risk of actually having it done.
Okay.
So if we can avoid a cesarean delivery by doing something which is non-invasive, like external cephalic version, then obviously that's a good choice.
Okay.
So there must always be a reason for a cesarean delivery before we actually go ahead with the cesarean delivery.
Okay. You're hearing this on Joy 99.7 FM, 23 minutes past the hour of 2. Obviously, the program is Ultimate Health. Obviously, with me, Nortey by nature, and I guess by now you're getting used to it. If it's obstetrics and gynecology, obviously it's Dr. Michael Macarthy, a good friend of the program in the seat. He's here from Sinel Specialist Family Hospital in Tema. We're looking at an obstetric procedure, right? My reading suggests that it's essentially an outpatient. You go in and it's done and you go. It doesn't involve surgery, relatively safe, but we're going to go through the details so you understand. WhatsApp is 055 11 11 997. I see some of you already popping up your heads there. Many thanks. We're live on Facebook and YouTube, so you're welcome aboard. It's a frequency, but ultimately, it's a family. Ultimate Health. Right. So we've come back to, things you are monitoring and reasons why you would want to do this. My understanding is that baby is very busy in there, changes his or her position often, frequently, and so on and so forth. That's why the imaging, the when you touch the stomach and all that, is that?
Palpation.
Palpation, you see.
Yes. These are big words for touching.
I like, because I do palpations, but for other reasons. No, I didn't want to say it, and then somebody would say, "Oh, Nortey, you wanted to say palpitation," and I said,
No, palpation.
I know, right?
Palpation,
Okay.
yes.
So when you're doing all those things, you are monitoring. When you do an ultrasound, that is imaging. You're trying to see what's going on in there.
Exactly.
Okay. So what would, you mentioned when to do it and so on and so forth. When, I just got pregnant, a little tiny weeny thing there, and then you want to move it. Would it be movable? Is there a time boundary where this is, should I say, indicated?
Yeah, the timing is very important. We know that the babies are moving all the time in the uterus, and so at the beginning part, we don't need to bother too much about what the position of the baby is.
Okay.
20 weeks, 26 weeks, 30 weeks, 34 weeks. From 34 weeks onwards, we want to take note of how is the baby lying? Is lying transverse, oblique? Is the baby lying with the head down or the breech down? But by 36 weeks, we want to take a decision because what the position is at 36 weeks is very likely to continue to be.
Okay.
So if at 36 weeks, head is down, cephalic, we're fine. If at 36 weeks, we are transverse, we are worried. If it's oblique, we are worried. If it's breech, we are worried. So we're looking at 36 weeks as the time. Okay. But of course, we start doing that monitoring at 34 weeks because they want to find out, so what's the reason? I mean, why are you not lying correctly? Or let me not say correctly, but why not lying in the optimal position for vaginal delivery? Okay. And they want to find the causes, the reasons like placenta previa, abnormal uterus, uterine fibroids, or problems with the baby, problems with the fluid, and so on. You check all that. But when you get to 36 weeks, now you need to take a decision. Okay, this baby is so-and-so position. What do we do? And that's when we plan. Okay. So we are going to do this procedure. Usually, I do the procedures at 37 weeks. Okay. It's easier to do the procedures before 36 weeks, but then you also have a higher risk of the baby turning back to its original position.
Stubborn.
And so you would not have actually achieved your goal. But if you do it after 36 weeks, there's only a 3 to 5% risk of the baby turning back to its previous position.
Okay.
So it's preferable to do this at 37 weeks, definitely above 36 weeks. And for us, we do it at 37 weeks.
Okay. Now, being a non-surgical procedure, and from what you've explained, are you taking this decision in conjunction, in discussion and collaboration with the mother, with the father? Can a woman refuse to have you flip her baby? How does it? How is this done? Do you need to give informed consent? How is it done?
Yeah, very important. I mean, this is a procedure that is being done on the mother, on the baby as well. And so the involvement of the parents is extremely important.
Okay.
Some women would request to have this procedure done. And others, you'd have to say, hey, this is the position that's going on. Okay. So we are headed for a cesarean delivery. Would you want to look at the option of having an external cephalic version?
Right.
If couple agrees, then you can go ahead. If couple says, no, we would prefer to have a planned CS delivery, or we want to wait, then you need to respect the wishes. So it definitely is in very close collaboration with parents.
Okay.
This is not something that the doctors can say, it has to be done. But the parts are clear too. If you have an abnormal presentation like, or abnormal lie like the oblique lie or the transverse lie or the breech presentation, the option there is then a cesarean delivery.
Okay.
And so if you're already planning for a cesarean, then you don't have a problem.
All right.
But if you're not planning for a cesarean, then you have that option to have an external cephalic version attempted.
Okie dokie. Can I come to you? I'm pregnant. You're monitoring me. You've done your scans. We're good like that. And by the way, the day Maryland said you're looking dapper.
Thank you. Thank you. Nice.
Hey, so you didn't see
nice
me.
Comment.
They didn't see me at all. All right. What I wear next weekend. All right. Anyway, so can I just come in? No problems, no issues. I'm fine like that. But I tell you, doc, I do not want a vaginal delivery. I just want you do a CS. For some reason, a woman tells you that. Is that done? Is it doable?
Nortey, I don't know why you like trouble this afternoon.
Because I didn't
now we are going into
no, I just want
cesarean section on maternal requests.
Right.
Okay, that's the whole topic. Maybe we should do that topic sometime. But yes, a woman can say that this is how I want to deliver. I would like to have a cesarean delivery on request.
Okay.
For various reasons that she may have. And that request has to be considered. And discuss risks mentioned and informed consent taken as well.
Okie dokie. 29 minutes past the hour. Let me come back to flipping the baby, right?
Yes.
Okie dokie. So we've got certain things you're looking at. You've talked about the number of weeks or the age of the pregnancy.
Yes.
Right? Where is it within term and all that? What else are you looking at?
Right. You would like to find out things about the mother, things about the baby, and then things about what's going on in the uterus.
Okay.
So mother must be healthy, baby must be healthy, and everything in the uterus should be normal. So for mom, you would want to look at are there any reasons why you need to have delivery now?
Okay.
Hypertension, some other complications of pregnancy. You need to deal with all that and make sure that the mom is okay. You need to look at the baby. Is the baby growing well? Is there enough fluid around the baby? Why is the baby in this position? Is the baby healthy and normal and so on? Check all that. You need to check on the uterus as well. Sometimes the position is abnormal because the shape of the uterus is also abnormal.
Okay.
Sometimes the uterine fibroids change the shape and the position of the baby, and there are other things going on inside the uterus. You have to be sure that the fluid around the baby is not leaking out.
Okay.
You have to be sure that this patient is not in actual labor, because it's much more difficult to do it in labor.
Okay.
Though some people in the literature talk about the fact that they can be done in early labor. That still can be a challenge because there are contractions and so on.
Okay.
So you want to make sure that things are really okay. You'd even do some further tests to find out where is the placenta located, because if the placenta is blocking the baby's path out, then you would not want to even attempt this. Or if there's any reason that already pushes the patient to a cesarean delivery, then you do not want to even attempt this. For example, if you had 2 previous cesarean deliveries, you do not want to attempt this, or there's a placenta previa that's covering the entire outlet. So you're not even going to attempt this at all.
Right.
So clear evaluation of what's happening to the mom, clear evaluation of what's happening to the baby and its current well-being, and then what's happening inside the uterus, you want to be sure.
Okay. Good afternoon, Nortey, and your resource person. He's Dr. Michael Macarthy. In the case that the baby is breached, what procedures are taken to bring the baby back to position? That's what we're talking about, or one of the things that can be done. Note briefly, it is not yet time for delivery, right? I think we've established the threshold. He talked about 36, 37 weeks, all right? And so I think that is taken care of. If not, send another extension to your question. This one says, oops, where are we now? Okie dokie. Yep. Let me go up. Nortey by nature. This one says, okay, I've read that. Oh, quickly. What am I doing today? Nortey, please, you didn't get back to me. Oh, you joined Dodua. Yes. The number was sent to me and then I misplaced it. It's been sent back to me. That's the menstrual thing we had last week, I think.
Right.
Yeah. This one is Dede in Maryland. Okay, he says your dog looks snazzy and dapper. No comments.
Thank you. No comments. Yep.
Is the inversion right? External cephalic or cephalic version, right? Procedure done with or without medications. If without medications, is it painful? Okay, we're going there.
Yeah, we're going there.
Are gadgets used for this procedure, or is it by insertion of the hand through the vagina?
So insertion of hand in the vagina is internal.
It's internal.
But this is external.
External manipulation.
This is external. So,
Yes.
so there's no insertion. There's no gadgets. There is no. Generally, there's no medication used here. So we're doing all this with external manipulation on the abdomen only. Generally, it's not painful. It's uncomfortable because you're pushing and trying to push the baby around.
Right.
So that level of discomfort may be there, but it's not a discomfort that requires anesthesia in most cases.
Okay.
Unless maybe you've done it first time and you want to do it again because it wasn't going well, then you could consider that. But generally, we do it without anesthesia. Most women tolerate it really well.
Okay.
And if it becomes too uncomfortable, we stop.
All righty. 34 minutes past the hour. 2 on Joy 99.7 FM. My name is Nortey by nature. I'm here with Dr. Michael Macarthy. We're pushing flipping babies. I watched a video of this procedure, and it was an Indian doctor, so I was enjoying the accent as well.
Exactly.
Right? The Indians do, and he says, you turn the baby in the direction its face is looking, or in the direction the baby is facing, right? And then that turn is he called it a forward something, somersault, no, something. There's a name like that, but we're getting there, right? So Doc has answered, no gadgets, no insertion of hands into the vagina, right? This is totally external and it's non-surgical.
Yeah.
And he will explain that, okay? I know my discerning listeners are in a hurry, but there's a reason why we're holding you back so that we get the steps. So we've got all these things. Mom is there, and it's been determined that she'll have this process. So she comes in normally, regular consultation. And then what happens?
Well, so we plan for it.
Okay.
She comes in, we assess her well-being, make sure she's fine, check her blood pressure, check her psychology, check what's going on with her, check that she's so happy to have the procedure done. She signs the consent form.
She can change her mind.
She can change her mind. It's her choice, so it's open to her.
Spoiled ballot.
Yes. Signs the consent form. It would be great to have a support person with her. It could be her husband, could be somebody else. It does not have to be her husband. Could be anybody else that she would like to support her, to be with her. It's an event, so it's nice to have that event, shared.
Okay.
So we do that, and then we want to check on the baby. How is the baby doing? Is there adequate fluid around the baby?
Right.
Because if there's not enough fluid, then it becomes difficult.
That's the
because
amniotic fluid.
Yeah, we need some space.
Right.
The baby has to have some space, and the atmosphere around the baby is the fluid, right? So that's what helps the baby to have enough space and room to turn, and you need some of that room to manipulate. And also when there's a reduced amount of fluid, it also is an indication that all may not be well with the baby.
Okay.
And you don't want to do this procedure on a baby that is already not doing well.
Okay.
And so you want to check on the fluid. We'll also check on the heart rate of the baby.
Okay.
To be sure that this baby is healthy. This baby is having a healthy heart rate. This baby is very happy with what is going on. You review again whether this baby is really still in the breech or the transverse position, because maybe it has even turned.
It had you talking.
Yeah. Sometimes they turn. We call it spontaneous version. The baby may just turn, and by the time you are ready to do your procedure, the baby says, "Hey, I'm already there."
Right.
And that's always nice.
Okay.
The baby has done your work for you.
Okay.
So that's nice. And even before this, we also want to check with mom whether it's actually feasible to do the turning. Sometimes you cannot actually feel the baby through the abdominal wall, either because the abdominal wall is very tense or because there's a large layer of fat on the abdomen, and then that becomes very difficult because you can't feel the baby well. You need to feel the baby. You need to touch the baby to see where it is, because you need to turn it from one position to the other, and if
Folks,
you don't know where it is,
you are hearing proper laying of hands. You need to feel, and yes, Doc, I'm glad you said that. Okay.
Yeah, you need to be able to determine, okay, so how is this baby really lying? And you need to be able to use your hands to determine what is going on inside the womb.
Right. Let me ask this, because you said I like trouble these days, but it sounds as if we're talking, or we've assumed there's only one baby. What if they're triplets or twins and they are sharing this bedroom, and then you are now coming to change bed sheets and movements and positions? Is this feasible? Is it indicated when there's a multiple pregnancy, Doc?
Right. So yes, there are some contraindications to this, and multiple pregnancy is one of the contraindications. So if there is more than one baby, you will not do external cephalic version, except in the situation where maybe you have delivered one and the uterus is relaxed enough for you to do an external cephalic version of the second one. But that's not a usual thing. That's not a very usual thing.
Essentially, we're talking about one baby, one pregnancy.
Yes.
Right.
Yes. So usually it's a single baby, and so you have the room within which to maneuver. Because if it's two, it's actually not very easy to know who you are really palpating.
Yeah.
It can be challenging.
And
then things can get quite complicated if it's more than one. Also, if you've had a previous cesarean delivery, even though universally it's not contraindicated for some, generally will not do it if you've had a previous cesarean delivery. Or if there's any other reason why you cannot have a normal delivery, we obviously will not do that. Yes.
Okay, let me deliver a couple of people via the phone lines. 030-221-6541. 030-221-6541. Ultimate Health on Joy 99.7 FM. We're talking about external cephalic version, turning your baby safely, turning your unborn baby safely, right? Doing the flip. Yes. We've covered who does the flip, and I'll come back to Doc because midwives can do it or are able to do it and things like that. If there's anybody who shouldn't be doing this, we need to know. 030-221-6541. Ultimate Health on Joy 99.7 FM with me, Nortey by nature.
Joy 99.7 FM.
Okay, so we're getting into the business. You still haven't done any flipping yet, right? So woman comes in, you check all these things. You're so diligent and so attentive to detail, but it's important because you started and you underscored and emphasized that achieving a safe delivery is your, paramount goal. So anything that might compromise that, you are concerned.
Very concerned.
All right.
Very concerned because you're intervening.
Yeah.
And so you need to be sure that your intervention is successful.
Right.
There are some complications which we need to understand so that we know how to get it done.
Okay.
Obviously, you could fail. You could try to turn this baby, and the baby would just not turn. And if you try this 3-4 times and it's not turning, you stop.
Okay.
If the baby is telling you, I won't turn, then you probably just stop, and go to
trouble
the next
before birth.
Yes. And of course, you can have problems with the umbilical cord because this umbilical cord is being, pushed around as you are also pushing the baby around. And so the baby may go into fetal distress.
Okay.
And that could be a problem. Or the placenta could separate. And so you'd want to be careful about that.
Okay.
And if the placenta does separate, you need to do an emergency cesarean delivery. Or if there's significant fetal distress, you need to do an emergency cesarean delivery. Sometimes labor can start because of what you are doing. Labor can start. And so you would want to do this, and that's why I won't do that 37 weeks plus. So if labor does start, labor has started and you are mature. Sometimes the membranes may burst open and the fluid will start coming out, and that could also be a problem. So about 5% of situations you may have some complications.
Okay.
But the success rate of this is between 40 and 60%,
right,
depending on certain things. I mean, even how the baby is lying is important. There are different types of breech.
Right.
We're not going to that, but if the legs of the baby are straight up from bottom over across the shoulders of the baby, then that makes it a bit more difficult to turn the baby. So you may want to check on that as well.
Okay.
So because of these complications that could happen, though infrequently, you need to do this in the hospital. Not only do you need to do it in the hospital, you need to do it in the hospital at the time when you have access to the theater.
Okay.
So if there's a situation where you need to have an emergency CS delivery, you will not be stranded.
Right.
So you don't do this in secret. You need to let your theater team know that this is what you are doing.
Not some kiosk in a corner somewhere.
Yes. And even in the hospital, you want to do it, in a space where you can easily get to the theater. You need the theater team to be aware.
Important
and the theater team should be aware. The other team members, the midwife and so on should be aware. So that if there is any intervention that is required, we can actually do that. If the theater is busy at the time, you wait.
Okay.
Till the theater is free.
Right.
And whilst it's being done, the theater should not be occupied.
So ECV is not an emergency.
No, it's not an emergency.
Right.
It can wait, but it can turn into an emergency.
Right.
And so
Okay.
you want to mitigate that. But remember that you're trying to prevent a cesarean delivery in the first place. So it's worth trying to get it done. And the success rate is good. Anything more than 40-60% success rate is really good. So you want to do it at a time of day when there is response time. You don't do this at midnight.
All right. Great stuff. Right. 44 minutes past the hour of 2. Phone lines activated 03022210. 0302216541. He tells me there's a caller on the line. Hello, good afternoon.
Already, okay.
Good afternoon. I hope you're doing well.
Yes, this is Ajingo, eh?
Yes, sir.
But you are not pregnant.
I have a program with my WhatsApp, so that's why I don't see me there.
All right. Please go ahead.
Yeah, I want to ask, for safe delivery, maybe you have touched on it, but I didn't think from the beginning, so pardon me.
Let me pause you slightly, Ajingo. Did you say self-delivery or safe delivery?
Safe delivery.
Okay, go ahead.
So when I talk about safe delivery, that the age of the woman matters. Secondly, if a certain woman decides that, as for me, when I get there, I won't let it to happen to the normal one. They should cut me and take the baby, and I should be free. Is that advisable? And what are some of the things that the women do that makes delivery difficult?
Jingle. You need delivery. I'm going to pause you there. What things that women do that make things difficult? Then he's going to go into and list them.
Why did he ask what men do?
Ajingo, you add the last one quickly. Oh dear. Right. He's going into, but he's saying that does the age of the woman matter? He brought in the question of requested cesarean section again, which we had dealt with. Okay. I don't know whether you brush up on that. And then, are there things that women do that bring about problems in delivery or pregnancy? But I think that's a whole, range of things that we can look at later in another program. But is age a consideration?
Well, age on its own is not a contraindication to external cephalic version.
Okay.
But different ages come with different other risks, and those other risks may then determine whether we should go ahead or not.
Okay.
Cesarean section or maternal request is possible, and that request must be tabled early so that detailed discussions can be had, and then adequate consent can be sought from the parents.
Okay.
What can women do to make things difficult? I think we should rather say, what can women do to make labor more easy?
Right.
And I think there's a lot of things that we could do to increase our chances of a normal delivery. But that's a whole. In fact,
program.
I must say, I am
A whole
setting up.
book that
I
you've
am
written.
actually setting up a whole masterclass,
Right.
online masterclass for how to achieve a normal delivery.
Right.
How to increase your chances.
Ajingo will not come.
Four secrets that actually work.
Right.
And I think that when we come out with it, we'll put it out so
Okay.
that people can do things that will then make it more possible,
Right.
more feasible, more likely to have a normal vaginal delivery.
Okie dokie. Dede is back. What if the baby isn't inverted due to its umbilical cord around the neck?
Yeah, if the cord is around the neck, you do not want to do this procedure,
Yep.
because then you are really increasing the risk of a cord accident, which can result in the death of the baby. And so you would want to check on that using ultrasound Doppler to see whether the umbilical cord is around the neck.
Okie dokie. Right. So can we, get some sense of what is being done externally by, in this instance, you, the obstetrician? What exactly do you do after you've assured yourself that everything is okay, green light is on, we have access to a theater, blood pressure, all that? I'm still lying there waiting. Doc, you haven't touched me. What exactly do you do?
Well, it has to do with so normally what I do personally is use a two operator technique where two people do the procedure together.
Okay.
The midwife plus myself, or another doctor plus myself.
Okay.
And then we'll identify the different parts of the baby by palpation through the anterior abdominal wall or the front of the belly, having positioned the patient. And then we will try to push the baby in the direction that we want the baby to go. So we'll determine how the baby should go.
Right.
Which direction is easier for the baby to turn. And then we'll try to push the baby in that direction using a particular amount of pressure to move the baby. If the bottom of the baby is very deep in the pelvis, of course, you need to bring that out a little bit first. So we'll push that out, and then that gives the baby enough space to turn. And then we'll push the baby gradually but firmly in that circular motion to turn the baby, or let me say, to somersault the baby. It kind of looks like a somersault. If you can picture that,
Right.
that's what really it looks like. It's like a somersault.
Right.
But it's very slow somersault, like a somersault in slow motion, let me say.
You're not in a hurry.
No, it has to
Slowly.
go slowly because, the baby is also in its delicate environment. So
Right.
you do that slowly, and you notice the baby starting to turn slowly across the various positions that the baby is in.
Okay.
And then finally, you may actually get the entire turning done.
Okay.
You may not succeed in the first try. You can do a second try,
All right.
or even a third try, depending on other things that are going on.
Yeah.
As we are doing this, though, we are also checking the heart rate of the baby.
Okay.
To see what is happening. Is the baby tolerating this procedure nicely? How is it going? We are also checking on the mom. How is she feeling in terms of pressure?
All right.
Most of the time, the pressure that we apply is not so high as to cause extreme discomfort, but some level of discomfort.
Okay.
And so we keep pushing until you actually feel the baby moving inside.
Right.
And they would describe that. Yes, I feel how it's moving.
Okay.
And that can be quite interesting. Depending on where you are starting from. If you're starting from an oblique lie, then it's a bit a shorter distance to turn the baby.
Right.
And not as dramatic. But the challenge is that it may easily revert back to oblique lie.
Okay.
And that could actually be a challenge. If it's transverse, usually a similar thing could happen. And so sometimes we do an induction at the same time. if you have those circumstances, version where the baby goes back to the breech position. So that also is possible,
Okay.
but not as common.
All right.
If success rate is 60% and reversion is 35%, I think that's a good deal.
Okay.
It's a good investment.
Right. So when you are doing this with alongside the midwife or another, professional, what you said was you're feeling the sides of the abdomen and so on, so you can actually identify where the head is,
Yes.
where the buttocks
And
are,
as it's moving,
so on.
yes.
And then you take a decision as to the direction in which you want to turn the
Yes.
baby, and then you start that manipulation from outside.
Yes.
Okay. Causing maybe amniotic tsunami.
Some kind of movement
Cause
of the
some
fluid, I'm
movement
sure.
of the fluid and the baby in the direction.
Yes.
And depending on how the baby was positioned, you may have a short distance to cover or a slightly longer distance.
Exactly.
If we use the phase of a clock, for example, then you know where you are turning to,
Theoretically, yes.
and you also know when you've reached your destination.
Yes, you should know when you've reached your destination.
Right.
otherwise you don't know when you've completed. But we always do this in conjunction with the ultrasound as well.
Ultrasound is helping
So
you.
we confirm at the beginning, we
All right.
confirm at the end.
Okay.
So we try in obstetrics to always use two modalities to check the same thing.
Okay.
So in this case, you do your palpation, but you also use your ultrasound
using
to
the
check
ultrasound.
before and after to be sure you've succeeded. yeah.
Okay, folks, what you're hearing means that if your ultrasound, which is really imaging, right, using sound waves, right, if it is showing that the baby's head is on your right, right, and then you go and feel and you say the head is on the left, then there's conflict. You need to reconcile that. That's why Doc is saying they use two sources or two modalities to check and make sure they are
As much as possible, yeah.
spot on. This is not lotto. They are not guessing. They need to be spot on, knowing what they're doing, do it safely, properly, and then it is done. If everything is okay, they wait for a bit, and woman is good to go.
Yes.
Right? Though he mentions that some babies are stubborn. He said, hey, who was that? And then they may revert
Yep.
to the position.
very possible.
Okay. He also said something. Let me just quickly pick up on that, Doc. You said that you wait and you check for labor. Are you suggesting that the ECV, this manipulation, could induce labor?
Yes, it could precipitate labor.
Oh, right.
Yes, which is fine. I mean, you're doing this at the time when the baby is ready for labor.
Okay.
And you are doing it in a situation where labor is preferred.
Right.
And so if labor starts, I think that's just fine.
Okie dokie,
Because then you have a baby that is smaller but is well matured.
Understand.
And, yeah, it should be fine,
Understood. Right. You also just brought in something else. The size of the baby.
Size of
There
baby
are
is
big,
key.
big
yeah.
babies and all sorts of. So, can the size of the baby be a reason why you would not want to do this?
Yes. Yes.
Right.
So if the baby is too big or the baby is too small, the baby is not growing well, the baby is too large, you would not want to do this procedure because then you create some other problems. So if maybe a vaginal delivery is not desired, then you don't want to do this. So if your baby is too big, which can be a problem, then you do not want to go with this. So both the size of the baby, position of the baby, and how the baby is positioned relative to itself are all very important factors to consider.
Great stuff. Very, 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 very revealing. The day is back. Doc mentioned that one has the choice of delivery by either C-section or vaginal delivery. I thought C-section is meant for delivery complications, therefore maybe an emergency option or intervention. If by choice, isn't that against the ethics of the trade?
Good question. So that's exactly why we are talking about external cephalic version.
Right.
So if you have an abnormal lie, like the lie that we described, either a breech presentation with dorsal longitudinal lie, or a transverse lie, or an oblique lie, then you are very likely to have a CS delivery.
Okay.
And we are saying that, can we change this narrative and say that even though you have these abnormal situations, can we turn that situation around and still go on to have a normal delivery?
Okay.
So we are looking at how we can achieve more normal deliveries rather than how we can achieve more cesarean deliveries.
All right.
So external cephalic version is doing exactly what the day is saying. We are turning the situation from a C-section to your opportunity of having a normal delivery.
Okay.
So that's what we're doing. The second part that she was asking about was cesarean or maternal request.
Yeah.
We need to understand that it's not all just medical, but there are other reasons why women would want to request for a cesarean delivery. And some of the reasons may not just be flippant reasons and I just want to have that. No, there may be very strong reasons behind that. And that's why if there is such a request, we need to have that request early enough so we can have a detailed discussion and really understand what is going on and mitigate all the factors.
Okie dokie. You want to be having your baby in the right place with the right professionals. I tell you, don't mess around with that. All right. Good afternoon, Nortey. How are you and Doc? Thanks for educating us on pregnancy. Please just ask the doc, if a pregnant woman walks to his office, will he detect if the position of the baby is not good, or he has to do the test before? Secondly, what happened to the first 3 months? The baby's head is downward and positioned, but at 4 months it turned upward. Hayford in Bator asked this. So do you just... A woman walks in, you know, or you think you know the position, and we mentioned all the images.
No, you need to check. You don't know. I mean, you cannot just look at somebody and say, hey, this position is abnormal. You may assume.
From the way you are walking.
No. But you need to, you can't, you may assume, but you need to check. There are some physical tests you do, and via the palpation, just even looking at the abdomen, second palpation, third using ultrasound scans, fourth using a vaginal examination, you can determine to a very large and accurate degree the position of the baby.
Okay.
But he raised important issues about the first 3 months and fourth month and so on.
Right.
We are only concerned, not only concerned, but we're basically concerned here with how the position is like after 34 weeks. And then we need to take a decision by 36 weeks what we are going to do. And so we're not talking about the early stages where there's so much room and the baby is swimming around and turning position all the time. We're talking about 34 weeks when it's more likely to remain as it is. And then 36 weeks by which we must take a decision so that we can plan for our delivery either by external cephalic version at 37 weeks or by an elective cesarean delivery at 39 weeks.
Okay, Doc. Right. You've mentioned some of the possible complications, right? Can we upgrade some of them to risks? Is the baby or the mother at any risk? Apart from, you mentioned those complications, but I guess this would be targeted at the safety of the mother and the baby, though you've made it quite clear and emphasized that you're monitoring this all along. Any known risks?
Yes. So like we mentioned, there are risks. And the whole idea is that can we do something that reduces the risk of the mother? So if you have an abnormal lie or you have a breech presentation, your risk of risk to the baby and risk to the mother is quite high, because you can get significant poor outcome for the baby with a breech delivery. You can have significant fetal distress or difficulties in delivery of the baby statistically over time. And so you want to mitigate that risk. So what we're doing is that we're trying to reduce risk. By reducing the risk of a CS delivery or a breech vaginal delivery, we are also incurring some other risks. But those risks are smaller in magnitude than the risks that we are trying to mitigate. And so what are the risks? The risks are fetal distress, rupture of membranes, onset of labor, problems with the umbilical cord, and problems with the placenta. These conditions can be quite significant, and so we want to make sure that we mitigate them and intervene should they occur. Right.
Wow, I can't believe it's 3 o'clock. Many thanks, Doc, for taking us through this procedure. If I've just listened to Ultimate Health Nortey by Nature and Dr. Michael Macarthy, and I'm interested in doing this, not necessarily automatically at Sinel, is it widely practiced?
Yes, I mean, most obstetricians, gynecologists can do this procedure. And if you're attending any clinic, you can just ask your obstetrician gynecologist about it. And he will obviously evaluate and tell you whether you're a candidate or not.
Okie dokie. Yeah. So, hey, you've got it. We inform and ultimately transform your options when it comes to health and wellness. That's what we've just done. My good friend Gershon Seckley. Gershon, you're a doctor now, eh? Is it Dr. Gershon Seckley? He's the CEO of G2 Medical Laboratories. He was asking whether all this is done with the assistance of the ultrasound. We've said that several times.
Yes.
So yes, the imaging is used to confirm,
Yes.
to determine many of the things that may be going on in there, right?
Exactly.
Okie dokie. Many thanks, Dr. Michael Macarthy, consultant obstetrician gynecologist with the Sinel Specialist Family Hospital in Tema. Look, I have loads to discuss with this man, but sometimes I feel very guilty pulling him from Tema because he's always working, right? He probably finished scrubbing after theater and put his hands on the steering wheel, and he's here. So we are most grateful to
welcome.
you and your team.
Thank you so much.
We still have an outstanding segment on prostate cancer, hopefully with Dr. Mary Bote. She'll come back, and I have another urologist at 37 Hospital. Maybe I'll pair them because the men were so into this, but a lot of them wanted and did send me messages on my personal phone. So I'm hoping we can push them in the right direction. We mentioned that men were reluctant, hesitant, resistant.
But if there's good reason, they come.
Yeah.
If there's good reason, they come.
So it looks like we're turning something around.
Yeah.
Once again, another healthy edition of Ultimate Health. We hope it was nutritious and easy to digest. If you have any questions, catch me somewhere or, send a message. We'll get it. Stick and stay on Joy 99.7. I know the... Abeku, I think today, Dreams FC, they've been dreaming they are in semi-finals. Somewhere out Egypt. They are playing in Egypt. And so, stick and stay on Joy 99.7 FM. My name is Nortey by nature.